to give the maximal benefit to the patient, to save as much as neurons as possible so that the patient have a better functional outcome. So let me start with our case presentation, an approach to stroke. A 53-year-old male, a 53, he got up in the morning and he was seen normal. He was seen normally reading newspaper at 7:30 a.m. And his wife saw him at that time, and she was serving him coffee. She talked to her. He spoke well. But at 8:30 a.m., she was surprised to see he was not able to speak, and he was not able to get up. He was not able to move his right side of the body. And this patient was brought to the hospital at 9:30 a.m. So here the timeline is very important. He got up in the morning. He was seen normal at about 7:30 a.m. At about 8:30 a.m., he was abnormal. Means that is the loss in normal time, the 7:30 a.m., which is very important. And he has some symptoms like he was not able to speak, he was not able to move the right side of the body. So the purpose or the occasion, on the occasion of the World Stroke Day, the logo goes like this: learn the signs, say it's a stroke. So we have certain signs for the patient, and we must say that it is a stroke. We should not be waiting for a laboratory test or a CT or an MRI to call it as a stroke. Arm or limb weakness and speech disturbances with imbalance or eye signs, then it is time to activate the stroke clock. It's time to act. And in stroke, minutes can save lives and save the precious time. That is the hashtag of the World Stroke Day, 29th October. So our patient is having stroke, and we should not waste time. Why we should not waste time? Because if we waste time, then we'll be losing the penumbra. We cannot save the neurons, and the patient will not have a good functional outcome, if not mortality. So if you see any of the symptoms, we call it as be fast for remembering it very easily. Anything to do with sudden onset of imbalance, or to do with eye signs, which are usually missed in some cases of stroke, which could signify a posterior circulation stroke. And most commonly, the facial weakness, the arm or limb weakness, and speech disturbances, don't hesitate to call that it is a stroke. So say it is a stroke. It's a clinical diagnosis. We do not wait for any major test to confirm the diagnosis of the stroke. And immediately we have to activate the stroke clock. So that is the system which we need to practice. And once a stroke is recognized, always you should think of getting a neuroimaging as quickly as possible. So once stroke is identified, it is a neural emergency. Emergent CT imaging is essential, because without that we cannot take a decision. So always you neurological emergency, and stroke is a neurological emergency. But before shifting to the CT scan, or while shifting to the CT scan, make sure that the ER checklist is completed. So what is the ER checklist? Everybody knows about that as an intensivist or anesthesiologist. We need to if there is a seizure, then we have to terminate it. We need to abort it. Check if the situation is code brain, means if there is any raised ICP, means if there is a clinical herniation. So that has to be attended to before shifting to the scan. But in most cases of acute ischemic stroke, but by this time we will not know whether it is an ischemic stroke or a hemorrhagic stroke in which a hematoma is expanding. So those scenarios has to be taken care of. And we do only a focused neurological assessment, NHS scale, which is the most commonly used scale to quantify the severity of the stroke. And we do a 3 point scale and a GCS can be done, and a brief history only. We don't go for a detailed history taking at this point of time. We can follow a format like ample, which indicates allergies, the medications, especially look out for the anticoagulants the patients are taking, especially the Novax, and past illness, a brief past history, and last meal, so that if the patient is subjected to GA, you might want to know that, and the exact sequence of events of how the stroke, how the incident happened. Laboratory wise, we don't want to have an extensive laboratory investigation at this point of time, but a capillary blood sugar is a must because hypoglycemia can mimic any neurological emergency. It can cause seizures, it can mimic weakness, it can mimic a stroke, it can cause anything. And a complete blood count and INR, which is to be sent, but don't wait for the reports to come to decide on any interventions. Don't waste time doing an ECG for this patient because the patient presenting symptom is the brain, not the heart. Only do ECG when there are pressing cardiac symptoms like severe chest pain or patient is severely breathless. Just that we should not miss out a MI or a aortic dissection. So once a stroke is identified as a neuro emergency, we always think of doing a emergent CT imaging or emergent neuroimaging, maybe an MRI. Also, we'll discuss that later. Why CT or MRI? But if it is a stroke, you can even bypass the emergency room because what did I tell you? The hashtag. So we can even bypass the ER. Why we can bypass the ER? For example, if a paramedic is saying that the patient is awake and responding to call, is breathing spontaneously, not tachypneic, the saturation is maintained, and the BP is more than 100 systolic, peoples are equal, and the patient is not having any hypoglycemia, then what are you going to do this patient in the ER? You're just going to change us. Okay, so that time also we don't want to waste. Time is precious, so we can bypass the ER if the pre-hospital checklist can be completed by the paramedic or the nursing. So once we do a CT scan, we know exactly what we are doing. Okay, so the CT scan could be absolutely normal, like the first picture. Don't get confused because in an acute ischemic stroke, if the patient comes in a time window period, the stroke must not have been manifested as an infarct in the CT, but still stroke is a clinical diagnosis. We need to say that this is a stroke and we need to initiate the treatment. Sometimes you can see some infarcts which has already set in the CT scan, or a hemorrhagic stroke could be there. That could be an intracerebral hemorrhage or that could be an SAH. In that case, our pathway should go in the direction of managing an ICH or a SAH. So, a simple imaging will differentiate what kind of stroke it is, and it is a must before giving any treatment. So, that is why I again emphasize the importance of getting a neuroimaging as quickly as possible because without doing an imaging, we can't decide on any interventions. So what is that we are going to do with the stroke patient? Okay, you identified, okay, and you established the time of onset of the stroke or the last known well, what is commonly called as. And we do a neuroimaging, and most importantly, the blood pressure control has to be achieved. We need to get the blood pressure if it is more than 180 or 185 to at least 185 to initiate the treatment, because more than 185, if you are maintaining the systolic blood pressure, we cannot initiate any reversible treatments. So we want to achieve revascularization either by medicines or by taking the patient to the cath lab and removing the clot out. And after that, what we do, we monitor for the cerebral infarction and swelling. We tend to prevent the secondary complications. We identify the risks and prevent a secondary stroke. And rehabilitation, of course, which goes hand in hand. So, this is the simple, basic focus in the management of a stroke. Identify a stroke, emergent neuroimaging, revascularization whenever possible, monitoring for cerebral infarction and swelling, preventing secondary complications, and risk factor optimization with rehabilitation. So NHSS is a scale which is most commonly used, which I told you. We'll be discussing this in detail tomorrow, how to assess the NHSS, which indicates the severity of the score. And once a plain CT scan is done, there is something called an aspect score. So the it all depends upon in what are the hypodensities which you see at the ganglionic and the supraganglionic level. So the maximal score is 10 and the minimal score is 1 or 0. Okay. So if the aspect score is less, then it indicates that then it is a severe form of stroke. So once we do that, immediately, if you can see in the plain CT, which is the first CT, you can see something called the hyperdense MCA sign, which indicates that there is a large vessel occlusion. And if it is followed by the CT angiogram, which will clearly show that there is a large vessel occlusion, there is an MCA cutoff. But after doing the plain CT, we need to find out if the patient is eligible for thrombolysis. If the patient is eligible for thrombolysis, which we call it an IVT, the intravenous treatment, that's the intravenous thrombolysis treatment, we immediately start the intravenous thrombolysis and then we do the CT angiogram. Why not MRI? MRI will definitely show diffusion restriction, which go a very clear image, which you can easily understand that it is a stroke. But the thing is that shifting the patient to MRI in acute situation takes time. And again, here time is precious. We cannot be wasting much time in doing MRI. And most of the decisions, the therapeutic decisions, can be taken with the help of a plain CT itself. However, there are situations where we prefer MRI. We'll come to that later on the discussion part. So once we do a non-contrast CT, you assess the eligibility for intravenous thrombolysis, that is the IVT. If the patient is eligible for intravenous thrombolysis, then administer the thrombolysis drug. If the patient is not eligible also, if the patient has been administered IVT also, do a CT angiogram. This an angiogram is a must. And if there is a large vessel occlusion, and if the patient is eligible for endovascular treatment within 6 hours window period, then the patient has to be directly transferred to the cath lab. If the patient is not eligible, or the patient is not in the window period, or if the patient is in the window period of 6 to 24 hours, then an additional imaging has to be done, like a CT perfusion or MR perfusion. And if found eligible based on certain criteria, like the dawn or diffuse trial criteria, then that patient will be shifted to the cath lab. If the patient is not found to be eligible, then the patient will go in for a standard care stroke pathway. So this is a imaging algorithm, and that is why it stress the importance of getting a rapid neuroimaging as quickly as possible. So a plain CT, you decide the patient is eligible for thrombolysis, give the thrombolysis, then do a CT angiogram. CT angiogram shows a large vessel occlusion. Within 6 hours, directly the patient go to the cath lab. If it is more than 6 hours up to 24 hours, then additional neuroimaging and the patient goes to the cath lab if found eligible. Otherwise, the standard care pathway has to be initiated. So these are some of the imaging checklist which you can have. Have a radiologist all the time. You just rule out an ICH or SAH. You rule out any prominent hypodensity. If there you see a very prominent hypodensity, then you rethink about the last known well or the last seen normal time, and you see whether the hypodensity is extending to more than whether there's a malignant MCA infarct that's already setting. In late presentations, look for mass effect and midline shift and calculate the aspect score. And after doing an angiogram, check for large vessel occlusion, the level of occlusion. And if you're doing additional imaging like a perfusion imaging, like a CT perfusion or MR perfusion, we need to know the core volume, the mismatch ratio, or the mismatch volume. And other additional findings will be there. There might be some incidental aneurysms, there could be some dissection, there could be some tandem occlusions, or there could be occlusion at more than one arterial territory. So these are all the some of the imaging checklist. So as I told you, if the patient is coming out of the window period, that is after 6 hours till 24 hours, which is an extended window period up to 24 hours, then based on additional imaging like CT perfusion, we decide on the eligibility and go for endovascular treatment. So this is the eligibility criteria for intravenous thrombolysis, which we will be detailedly discussing tomorrow. Okay, if the patient is found eligible, then we have to go for thrombolysis. And this is the eligibility criteria for endovascular treatment. There is an eligibility criteria if the patient present within 6 hours, or there is an eligibility criteria if the patient present within 6 to 24 hours. So based on that, if the patient is found eligible, we'll be going for endovascular treatment. That also we'll be discussing it in detail in tomorrow's class. So once found eligible, after an IV thrombolysis agent is administered, whether it could be tenecteplase or alteplase, or if the patient is out of window period, out of 4.5 hours, or if the patient has directly shifted to the cath lab, then the patient undergo a mechanical thrombectomy. There are various devices which are available. There is a stent retriever, there is an aspiration device, and there is a combo of these devices which are, in fact, some rescue therapies sometimes could be done in terms of intra-arterial thrombolysis and others, which are rescue therapies, and that also can be done. So once the clot is removed, then the vessel will be opened up, and this is how the vessel opens. If there is a cut off, there is an MC occlusion, and once the clot is removed, then the vessel will open up. But there are certain unfortunate patients who are not eligible for this procedure, or who come or present very late. So what can we do in those patients? So those patients, if they qualify based on some standard indications, like the within 24 hours, you could predict that this patient will go for a cerebral swelling and herniation, then the patient should be subjected for a early decompressive craniectomy, which not only is life saving, it could offer morbidity benefit also, means it could improve the functional outcome also. So this is in nutshell about approach to a stroke. And more importantly, we need to create systems of care. So stroke is a disease where we need to create systems. A system which is working in my hospital may not work in your hospital. A system which is working in the United States may not work in India. So we need to create our own system. But the essential core remains the same. Means we need to achieve the revascularization at, as quickly as possible. And for that, the patient has to come to an appropriate center. An appropriate specialist should be available, and even if the patient comes to the appropriate center, a team has to be there so that the patient gets the treatment as quickly as possible. So we assess this in terms of door to needle time and door to groin puncture time. So this is what is essential. We need to create systems of care which will improve. With this, I'll conclude my talk on the approach to stroke. Now we'll be having an interactive discussion with the faculties on how they approach the stroke, and some scenarios also will be discussing. So let me present a slide here, and we'll ask the faculty on how they go about with this situation. And first, I'll introduce Dr. Raj to you. Dr. Raj Parthasarathy, you are here. So, in the approach to stroke, we are discussing about neuroimaging, which is very essential. I think you would agree with that. We need to get the neuroimaging as quickly as possible. And in that, with that regard, there's always a confusion whether to go for an MRI or CT. Different hospitals practice different protocol depending upon the availability of the radiologists as well as the availability of the softwares which are there, especially in the out of window period. So, just can you give a brief on neuroimaging? Which one we should choose in what setup?
So, as you had rightly mentioned, it is actually a hospital based approach because it depends solely on the availability of the MRI. So, some centers have access to MRI on an urgent basis. Then it is possible to have an MR based protocol. Otherwise, a CT angiography will suffice in most of the cases. So, if for up to the 6 hours window, then I think a plain CT angiography, if at all, because if we want to decide on major vessel occlusion, we would like to have a CT angiography. But if you want to just thrombolize, a plain CT alone will do in the first 4.5 hours. So, up to 6 hours, CT angiography, head and neck vessels will suffice. But beyond the 6 hour window, we need to have some advanced imaging to look at the core and the penumbra. So what we do at our center is we get a quick DWI along with the CT angio. The other options would be just have an MR DWI alone, along with MR angiography head and neck. So all these trials have looked at the core volume. Actually, the penumbra volume is not going to decide the outcome. The core is going to decide. So If you have just a means of getting the core either by MR or CT perfusion imaging, that will suffice. So in the earlier center, previous center, we used to do CT and CT angio, and CT perfusion imaging. However, as I mentioned, all these trials have looked at the core and not the penumbral volume. Even though they have given the ratio of core plus penumbra to core to be more than 1.8, but still, I think core volume alone will do.
Yeah. So, Doctor Raj, as you said, you are going based on MR based protocol, isn't it? Yeah.
Yes, yes, yeah. Beyond the window period, I think we just use a DWI. So that will give us the core volume. And the clinical, so if the patient has a large deficit and the core volume is smaller as compared to the deficit, then we go ahead with mechanical. Of course, more and more evidence. So you talked about the aspect score. So previously, the aspects, they used to say 8, 9, and 10 would have a good outcome. But recently, a trial from Japan, which had looked at larger cores. So even I was not a proponent for patients who have large cores. But this trial, which has been recently published, has looked at aspects 3. There was considerable number of patients. And even in that group, there was a benefit. So now, essentially, even beyond 6 hours, if you go to the West, they would be intervening in a large vessel occlusion, irrespective of the core volume. It seems aspects 3, which means a core volume in that study was almost 90 mils, almost in one arm and 100 ml on the other arm. So previously 50 ml was a cutoff, then it went up to 70 ml. Now it's going up to 100 ml. And the time to reperfusion was also 5 hours. It was not in one study. It was within 3 hours of onset, but in this study it was up to 6 hours. So I think if you can assess the core, and unless the entire territory is involved, I think there is a option of going endovascularly if there's a major vessel occlusion.
So, you think even in the patients presenting within 6 hours, that's a way to go forward, or a CT is
I
much,
think within
you can save
six
the
hours
precious
we
time
can.
by doing a
I
CT and
think we can within 6 hours just go for a CT angio head and neck, and that would do. That would suffice. If you have an MR based protocol,
that
just an
sounds.
MRI, DWI with MR angio head and neck. And beyond 6 hours, I think you
This
need
is
to have
the
the code. The reason for that is that it takes 2 hours or more. So if you go for a CT, it takes like 2 hours for these changes to be discernible to the naked eye. So for example, infarct tissue has occurred already. You need a 2 Hounsfield unit drop, and this 2 Hounsfield unit drop, for you to see it clearly, will take at least 2 hours. So maybe the whole territory is infarcted, but you may not be able to visualize it on a plain CT. Of course, you need to window the CT to get a better differentiation between the gray and white matter. And if you don't window the CT, again, you will miss many times you will miss the infarct core. So we do the windowing to 40-40, and then you will be able to better see the discrimination between the gray and white. And if there's a loss of gray and white, then we know that that area is infarcted.
I'll just get a quick opinion from Dr. Amit as well. Dr. Amit, in this topic, yeah.
I pretty much agree with what sort of Raj has said. I would probably stick to the same principle. Saving time matters within the first 6 hours. So CT angiogram would suffice in the first 6 hours. Beyond 6 hours, yes, diffusion and CT angiogram it requires CT perfusion. So because of course we follow rapid sequence MRI based protocol. Here within 6 hours, if you are able to save time and if you are able to give substantially delete the unnecessary sequences and finish the whole sequence in about 8 minutes, 8 to 10 minutes, then it's worthwhile even considering an MRI based protocol. However, it's as you already put it in your slides before. It's important to have your own hospital specific protocol where you can save time so that the constraints are minimized and you can subject the patient to urgent IVT.
All right. So, let me go to this case scenario. This is a young female who had been operated for a mitral valve replacement with atrial fibrillation. She was on a oral vitamin K antagonist, that is acetylone 4 milligram per day. and she was okay till 7:30 a.m. But at 9:30 a.m., in the living room, she was not able to speak, not able to move her left side of the body, and she reached the hospital. So let's all shout and say that it is a stroke because she's not able to speak. It's sudden onset, not able to move her left side of the body. And on reaching the hospital, she was awake on stimuli. She was not talking, no tachypnea. The BP was on the higher side, and the CBG was 86. And let me ask Dr. Saurabh, what will your team do at this point of time? Dr. Saurabh.
Yeah, hi. So the blood pressure is 200 by 110. So there are two things which are there. Patient is already on warfarin, and blood pressure is more than 200 by 100. So a quick INR check, uh, and to decrease the blood pressure. So we will use labetalol to decrease the blood pressure to less than 185 by 110, and try to maintain it if, after that thrombolysis to less than 180 by 105. And labetalol or labetalol infusion, but it's a weak hypertensive, antihypertensive, as we all know. Sometimes it doesn't work in ER, and we don't have the liberty of using enalapril or hydralazine with us. So we generally go with sometimes we have to go with NTG as well, because we need to thrombolyze. See, in India, there are less number of patients who reached to hospital in time in window period. So we need to give them the therapy. We have need to give them the chance. After that, we can sometimes we put a Riles tube also prior to thrombolysis, and start oral antihypertensives after to maintain the blood pressure, because after the thrombolysis we can't put a Riles tube in fear of bleeding also. So
So
we generally
actually, I
go with
wanted to
labetalol.
ask. Yeah, I want to ask this question because you see in most of the instances, what are the drugs which are recommended for this purpose, except for labetalol, are not available in India. So IV
Yes.
nicotine or the
Yeah.
DVD.
Yeah.
So how do you manage with the
So we
with that
we
handicap? How do you manage
uh,
blood pressure? That's a
so
thing.
I
And we
told
also
you
know
we
that without reducing the blood pressure, we cannot go for any intervention. Or be it a hemorrhagic stroke, also we need to control the blood pressure. At this point of time, we don't know whether it's an ischemic stroke or hemorrhagic stroke. So
see.
as you said, you are using NTG. Yeah, in our
So
place we
we
use
are
even
using
IV.
NTG, we are using NTG, and we are using high dose of labetalol infusion. So we go up to 2 milligram per minute as well in these patients. Okay, so a high dose of nimodipine, high dose of labetalol with the use of NTG will decrease the doses of NTG which is required. So and we also know that vascular edema is going to develop after 3 or 4 days, not in acute 24 hours. So in the initial time period, our goal is to decrease the blood pressure and to maintain it. Okay, so that is why I told you the handicap is with the labetalol, and we all know that it's a weak antihypertensive, and sometimes it doesn't work. So there are two drugs with us. One is NTG and one is nimodipine. Nimodipine we generally don't use because it's again a vasodilator. We know that it's a vasodilator. We are using in subrectal hemorrhage it as a vasodilator. So initially we started using it, but we have stopped using it. Uh, we all of us are more comfortable with NTG. We have used it day in and day out. So better titration of the blood pressure is available with NTG. So when labetalol is not working, at the same time we put a Riles tube prior to thrombolysis also. We and post operatively it is very helpful to maintain the blood pressure to less than 180 by 105, but we use a labetalol and NTG combination in ER.
I get the opinion from Manish also because this is the thing which most of us want to know. Dr. Manish, yeah. Manish, please unmute your mic.
Although we do not use NTG, we use nimodipine, and the drug of choice is labetalol. Very high dose of labetalol can be used. So if the blood pressure can be controlled with these drugs, then it is okay. We thrombolyze, otherwise we do not. But in this case, the patient was also on acetrom, so that we need to see INR also. If it is more than 1.7, that is another contraindication for thrombolysis.
All right. So that's pretty clear. We are just handicapped with only labetalol. The other drugs which are recommended by the guides are not available with us immediately. So as per the experts, some are using IV nimodipine and some are using even IV NTGs, which is not regularly used in the neurological emergencies to control the blood pressure. And I'll go to Dr. Amit. With respect to minor strokes, so the so-called minor strokes, sometimes we have a dilemma whether to, even if the patient presents within the window period, to thrombolize or not to thrombolize. And more dilemma is that when the patient has got a large vessel occlusion, but the stroke severity is only qualifies for a minor stroke. And that this dilemma especially is more severe when it's with respect to a posterior circulation stroke, that is a basilar artery occlusion. So how do you go about in these scenarios? A minor stroke, but whether to thrombolize or not, on the minor stroke with a large vessel occlusion in the anterior circulation as well as in the posterior circulation, these three scenarios, how do you approach this and what is your practice?
So the earlier stream of thinking was regarding NIHSS being more than 4, and when the NIHSS is more than 4, we consider thrombolysis. But things are rapidly changing. Things are also changing when there's a large vessel occlusion. What happens in a large vessel occlusion is this patient can actually progress and develop a larger infarct with substantially bigger core at some later point of time. So in such patients, actually, sometimes whenever the deficit is significant deficit, for example, if an IT professional who presents to you with aphasia, or who presents to you with hemianopia, or who presents to you with any major, which is not very high on NIHSS, but a deficit which is quite substantial. So in such a patient, you should give him the benefit of thrombolysis. And any substantial demonstrable deficit, I would definitely consider thrombolysis, even in minor strokes. That is answering the first part of your question. Now, the second part of your question was, whenever there's a large vessel occlusion, whether we thrombolize or, and then we take them for endovascular, was it the right question? Or when do we consider them for thrombectomy?
No, minor stroke with a large vessel occlusion. I was asking for endovascular interventions, whether we'll err towards endovascular intervention, or you think that you will assess the collateral status and then decide, and what is the protocol for the anterior circulation?
Regarding firstly, when I spoke about the first part of it, which is I'm not talking about LVO at all. I'm just talking about small strokes. In which case, I will still consider thrombolizing this patient. So that's the first part of it. Now, whenever there's a large vessel occlusion, and you have then whether the patient is coming within the window period and whether there's a demonstrable deficit. So whenever the patient still presents within the window period with a demonstrable deficit, I will do IV thrombolysis, take him for a DSA, and look at the large vessel part. If you've already done a CT angiogram, we'll assess if there's a large vessel occlusion already or not. If there is a large vessel occlusion in this patient, and if I see that there is, if he is within that within 6-hour period, then I would still consider him for mechanical thrombectomy, because this patient can still worsen beyond that conventional window period. However, if this patient is beyond the conventional window, I would definitely like to get a CT perfusion in this patient, and I would definitely look at mismatch ratio and core volume and everything. So if that is there, if the patient fits into that particular criteria with a substantial penumbra, so in this patient I will still consider going ahead and doing a EVT.
Dr. Raj, may I get your opinion on this minor stroke and a large vessel occlusion within 6 hours, after 6 hours? How do you approach this?
Oh, so that's a difficult question to answer, because around 30 to 40% will deteriorate. But however, if you look at the literature, what it says that if it is a minor stroke and LVO and you have offered EVT, it does not add any benefit. In fact, there are more symptomatic intracerebral hemorrhages. So in these instances, what I do personally is to monitor these patients every 15 minutes, half an hour. So clearly explain to the family that there is a very high chance, 30-40% chance that this patient will deteriorate in the next, particularly the patient is in the first 12-hour window. I've seen that these patients do deteriorate, and give the option to them that we can do it right now, but there is no evidence in favor. But if the patient deteriorates, then we repeat the stroke protocol imaging. And if the core is still low, then we go ahead with thrombectomy. So, for example, we had a basilar artery occlusion with no deficit recently and deteriorated 7 hours later with left-sided weakness, and we went in mechanically at that time. So, difficult question, but there is no evidence in favor to offer endovascular thrombectomy right now at the onset. I mean, at the outset, basically, if there's a minor stroke, minor deficit. On the other hand, if it's a disabling deficit, that's a different thing to answer. Like if the patient has a significant deficit which is disabling, then again, we don't have answer if the NIHS is less than 4 for endovascular thrombectomy. For, of course, for thrombolysis, we have to thrombolize. It's a class 1 A evidence now for a disabling deficit for thrombolysis. It
And
may be NIHS is less than.
so in this regard, will you do additional neuroimaging like assessing lateral status, especially in the anterior circulation, and based on that you take a decision?
It's always worthwhile, but again, we can do a DSA, because what happens is if you do a penumbral imaging, there will be a big penumbra. There's no doubt there will be a big penumbra in almost all of these patients. There's going to be a big penumbra and a small core. So we cannot really base it just by the penumbral volume alone, because there will the collateral status. Of course, we can have collateral imaging. We can do a DSA check for the collaterals. If there are good collaterals, then the chances that the patient is going to deteriorate is less likely. But again, all these studies have not shown a benefit at the outset of going endovascularly. In fact, they have said that SICH risk is higher in the subset of patients, and therefore there is no recommendation as of now to go ahead with thrombectomy at the outset. But yes, keep a very close watch. If they deteriorate, then we repeat the imaging, and then we just only the core imaging, and then we go ahead with thrombectomy.
Okay, so you are pretty clear on what you have to say. There's not much evidence in this. So in this patient, the CT scan was done. And there was no hemorrhage, and there was a large vessel occlusion, and she was offered a thrombectomy. What I want to ask here is, she was on acetylene. So we know that acetylene, as such, a patient if taking an acetylene, we need not wait for the INR report. That's a guideline. But if the INR come as I think greater than 1.6, then we stop giving the IV TPA. But nowadays we are using tenecteplase. We are just pushing it. So with respect to patients on oral anticoagulation, so how do you go about thrombolizing the patient, or you shift the patient directly to the cath lab without thrombolizing the patient if there is a large vessel occlusion? I'll go to Dr. Amit first, and then I'll come to Dr. Raj. Dr. Amit.
So in these people, if we know that when was the last dose that the patient.
Dr. Amit, we can't hear you very clearly.
So
Yeah.
Am I audible now?
Yeah, better, but not. Yeah.
Yeah. So my what I was trying to tell is that somebody presents the patient is on NOAC, for example, patient is on dabigatran, or patient is on rivaroxaban or apixaban.
I think Amit, your voice is not very clear. I think maybe some mic setting.
So it looks okay from my end. So
Okay, can you just come closer and then talk? Yeah, yeah.
Yeah. So what I was trying to tell is, somebody is on NOAC. If somebody is on NOAC like dabigatran or apixaban, what you would see is when was the last dose we had taken it. More than 4 half-life. For example, if patient has taken more than 48 hours or more than 22 hours back, you can still consider this patient for IVT. While if somebody is on warfarin, if INR is say 1.7 or more than that, so in that situation, I would not consider him for IVT. Because INR would take my terms at that point of time. But if NOAC things may be easier if we know that then we have taken the last dose. When we don't know that, we can do what is called as an indirect evidence, which is either doing thrombin time or by doing what is called as APTC. So roughly, if the thrombin time is closer to normal and if it's not prolonged, it means that your NOAC is not working, which means you can consider this patient for IVT. Why, if even this Icarian plotting time can be used in such a situation, but it's not readily available. So thrombin time may be you. APTT being prolonged more than 1.5 or 2 times more than normal, maybe another indicator that somebody is on NOAC. While if the patient is on warfarin, I would just do an INR, and INR of more than 1.7, I would not consider him for IV.
Okay, let me go to Raj on this topic. Raj, can you just make clear because we didn't hear him very clearly? Yeah.
Yeah. So for acetrom more than 1.7 or more, then we'll have to go for a direct mechanical thrombectomy. Your
But
question
we'll
about
not
whether
be
you
getting the
directly,
report immediately. Yeah, we'll not be getting the report immediately. So the
yes.
decision has to be taken right now, whether to give or not
So
give. So
if
the
if
guidelines
I
say that
have
you can give. Yeah.
if I have the angiosuit ready, I will directly shift the patient to the angiosuit. But as I said, if the patient is on acetrom, I think we need the INR to thrombolize. If the patient, as a routine, I don't do INR for any of my patients. But as you had mentioned, up to 2 INR, there was a smart study in the US, up to 2 INR, patients didn't really have more bleeds as compared to patients who are not taking acetrom. Having said that, I think with the current scenario where any bleed is not acceptable for a patient, I think INR 1.7 and more, we have to be careful about giving it because patients are very difficult to manage nowadays if there is a bleed. With regards to NOAC, as Dr. Amit had mentioned, patient should have been off a NOAC for 48 hours to thrombolize. If you have patient is on dabigatran and if you can administer idarucizumab, then you can administer idarucizumab and then go ahead with thrombolysis. For apixaban and rivaroxaban, they should have been off the drug for 48 hours. With regards to monitoring for dabigatran, you have to do thrombin time. APTT alone is not good enough. It will be normal, even if the dabigatran is functioning very well in the therapeutic range, because as you know, the APTT will not rise, and it will be only the thrombin time which will go up with dabigatran. Apixaban, we don't have the reversal available, and dexanet alpha, but I don't think it's a great reversal drug either. And so coming on to what is the other part of the question? Uh, so I think
Yeah,
that's all we have covered.
taking the patient, taking the patient directly to the angio suite, even in otherwise, if the patient is not taking anticoagulants. What is
Okay,
your take
so
on
there
that?
is a recent SWIFT direct trial that has been published from Switzerland, which looked at bridging versus no bridging. And clearly, the good outcomes were better in the bridging arm as compared to the direct thrombectomy one. This was a non-inferiority trial of direct thrombectomy versus thrombectomy with IV thrombolysis. So it didn't show that it was not non-inferior. So we would bridge wherever possible. There is a direct safe trial from Australia, which also didn't show non-inferiority. So at the current moment in time, I think we have to thrombolize if at all possible. Second thing is there was this trial from another trial after thrombectomy. They had given alteplase and shown. So whenever we do thrombectomy, there will always be some distal emboli. And after thrombectomy, even if you have had successful reperfusion, there will be some distal clots. And if you have given alteplase in that particular territory, they were had much better outcomes as compared to just thrombectomy. So currently, no evidence to suggest just direct thrombectomy alone was good.
Okay. And take on wake up stroke. So how do you approach wake up strokes?
Uh, s- so
Dr.
what
Raj?
we do at our center is I do an MR DWI flare. Okay, so if there is a concept called as DWI flare mismatch, and this mismatch is only to look for to age the time of infarct. So what we know is most of the wake up strokes, the stroke has started just before you have woken up. Based on the pre-flare study, wherein if there is a DWI positive lesion but a flare negative lesion, then we know that the onset is less than 4.5 hours, and this patients can be thrombolized. So that is a very good way because the rest of the core penumbra doesn't really age the time of onset. So pre-flare study is probably the saver for us where we do the MR imaging. You need MR imaging for that. We cannot just go by CT angiography.
Can you just explain
For
something
all
about
other,
this?
for mechanical, we go for the routine criterion. So At the moment, at the current moment, although the aspect 6 and above, now we are taking larger course. Um, um, I personally have gone up to 4 and 5, not to 3, but there is emerging evidence that even at 3, potentially patients would be benefiting from, meaning a core volume of nearly 90 to 100 ml. In the past, IMS 3 failed because of that, but now there is a lot more evidence being generated that so in the interventional arm, 33% had a good outcome as compared to 8% in the standard arm. So this is a trial from Japan, actually.
So, with respect to the neuroimaging in the wake-up stroke for deciding the eligibility for thrombolysis, can you just explain that diffusion flare mismatch for benefit of our viewers? Yeah.
Okay, so we cannot, in a wake up stroke, we cannot just go by CT angio. You need to have CT perfusion or MR imaging, right? So I would prefer MRI because that will age the time of onset of stroke. So we do, in our center, we do three sequences. One is the DWI, a flare, and an SWI imaging. So the DWI will tell us what is the infarct core. Okay, and flare, usually the onset of changes in the flare, it takes 4.5 hours after the onset of stroke. So if the area is positive on DWI, you see a DWI hyperintense area, but nothing on flare. There is no hyperintensity on flare. That means the onset is less than 4.5 hours, and therefore it is still someone who can be potentially benefiting from the thrombolytic drug. So that is why we do MR imaging. I would suggest MR imaging in wake up stroke if you're going for thrombolysis. But if you're going for mechanical thrombectomy, both MR imaging or a CT perfusion imaging would be adequate to go ahead with that. But many of the neurologists also have this, that if there is a DWI flare mismatch, they feel that the core is the infarct core has not established. But that is not true, because flare only times the onset of stroke. It doesn't really. The DWI volume is the core volume. So that is the infarct core. The flare, many of them think that if only it is there on flare, then it is an infarct. And sometimes the concept of DWI reversal is there. However, if you look at the papers, if there is a 1 mil core, it can become zero point 0.5 mil, but large cores don't reverse. But if you go into depth of DWI, there is something called as kurtosis imaging, because it is not what we assume in the MRI is that the cell is made up of water and the water is freely mobile. But in fact, within the cell, you have a lot of organ structures. And therefore, we don't account for this organ structures because there will be some restriction of movement of the proton within the cell. So we have now what is called as kurtosis imaging, which is a DWI type of imaging, but it takes a long time to do it. Therefore, with time, the DWI, there will be advancements in DWI imaging to actually find the scope. Some of them may be not true. So one other thing is, many people talk about reversals, but we say, for example, you have done DWI on day 1, and day 2, you see the entire DWI lesion is gone. And you have to really repeat it on day 5 to know actually if the DWI has reversed or not. So that is called as false reversal. So you need to have a repeat imaging 4 or 5 days later to be sure that the DWI has reversed, because after day 1 you will have some vasogenic edema. So then what it does is, initially it is cellular edema, cytotoxic edema, when the occlusion occurs. Day 2, you can have a component of vasogenic edema, which will show that it is a false reversal. But eventually you will have an established infarct, which will correspond to day 1 MRI if you do a day 4 or day 5 MRI. So DWI reversals are extremely rare, and whatever reversals that have been put in literature is 0.5 ml to 1 ml or so, very small volumes.
All right. So this becomes more delicate when we deal with the posterior circulation stroke also, because the diffusion flare, the mismatch was studied only in the anterior circulation. Sometimes we get some cerebellar infarct and with the wake up stroke. So what do you do? You never thrombolyze, or you still offer thrombolysis for such patient?
You want Dr. Amit or
Dr.
myself?
Raj?
Okay. So posterior
Dr. Amit,
circulation.
is your mic okay? Because
Yeah. So I think I would still consider this patient. Again, sometimes these are difficult patients because they are posterior circulation. Am I audible now? Am I clearly audible?
yeah, yeah, you are very clear. You are very
So,
clear now.
so,
Yeah.
so basically, even in posterior circulation, I would still go by the same diffusion flare mismatch as well. However, that's not as well studied in terms of posterior circulation. Uh, but if somebody is presenting within that with a diffusion flare mismatch, you still can consider him for IVT. We could consider such a patient for IVT, irrespective of
All right.
where the infarct is.
All right. You agree with that, Dr. Raj? Yeah.
Yeah, I completely agree with that because I think the issue with posterior circulation is that sometimes even the DWI lesions are not picked up. In 15-20% of patients, you don't pick up lesions on DWI because I think they try to do fast imaging, and what happens is they do up to 5 cuts. So in these cases, sometimes even when I have doubt in DWI, I strongly consider there should be a lesion. What I do is a coronal DWI. So I do imaging in an axis which is perpendicular to the initial axis, and most times than not, you may pick up some changes. With regards to thrombectomy, all these trials which have been negative with thrombectomy is because these trials have been going on for 10, 11 years with an older generation devices. So there's a trial which has been published for thrombectomy in basilar artery stroke, and it shows that there was no difference. But I have to strongly disagree with that. It's just because the trial has been going on for 10 years, poor recruitment, and earlier generation devices were used for those trials. And therefore, really, there has to be another trial to say that it will not benefit in these subset of patients. Only thing is, I go by there is a DWI score, brainstem score. I don't go by the aspects one because it doesn't really include the medulla. I think medullary region. If I'm wrong, you can correct, Dr. Amit. So the brainstem score really looks at the midbrain, pons, and medulla, and it is at each level you have 4 points, right? So four in the midbrain level, pons in the medullary level, and so total of score of 12 points. And as per literature, if you have four or more, the outcomes are generally going to be poor. But as a thumb rule for me, if at one level both sides are involved, say at the midbrain level, the right and left midbrain is involved, and you see it clearly in two cuts, then that patient is unlikely to benefit from thrombectomy.
All right. So now one more question. Just some quick questions. Dr. Saurabh, I'll ask you. Alteplase, tenecteplase. So what do you use now? Unmute your mic here, please.
We use at place only. We don't use connector place at our place. Dr. Raj has used in one or two places. He can answer it better because he is the one who is deciding whether to use it in active place or in active place.
Dr. Raj,
See, the ACT trial has come in which shows that tenecteplase is non-inferior to alteplase. So I have personally used in one or two cases only, but it does seem that it is non-inferior to alteplase, and it can be just a personal choice of what you want to use. However, as you know, tenecteplase is a superior molecule. You have some three domains or three sites which have been altered in the alteplase to give higher fibrin specificity, reduce the plasma clearance, and also resistance to plasminogen activator inhibitor. So these three makes that it is half-life is longer. Although they say it is fibrin specific, still there will be say for example with alteplase, your fibrinogen will start dropping, and I would say it can drop for up to 2 days to 3 days. It may take up to 2 to 3 days to recover. Even with tenecteplase, although it is fibrin specific, what I mean by fibrin specific, it will activate only the plasminogen that is bound to fibrin. It does activate plasminogen as well, and there is defibrinogen even with tenecteplase. Although they claim it is higher fibrin specific, there are up to 25% of patients can have defibrinogenemia. So definitely yes, a superior molecule. The first study has shown positive trend towards being using tenecteplase at 0.25 milligram per kg. Although the Indian guidelines is 0.2 milligram per kg, potentially this might change to 0.25 milligram per kg. In the international trials, clearly in major vessel occlusions, tenecteplase has shown that it has opened up arteries better than alteplase. So I think whatever you want to use, you can use.
Dr. Amit, what are you using now?
So I think it's a toss-up between the two. I mean, as Dr. Raj rightly put it, it has got a great promise, tenecteplase. As of now, we are using both the molecules. Of course, now we are also hearing that in up to 4.5 hours, the DCGI has just given approval for tenecteplase as well. So that's yet to reach our, in the form of guidelines to us. However, this is the internal talk saying that up to 4.5 hours, even tenecteplase has been approved. But having said that, tenecteplase seems to be a superior molecule. I completely with Dr. Raj on that. And it has opened up a significant number of large vessel occlusions by itself as compared to alteplase. So the promise is there, but as of now, I would only consider and tell it that this is non-inferior, and I would consider both the options as of today.
All right. So once we thrombolize, once we do a thrombectomy, we need to start them or put them on antiplatelets. So can you just brief our viewers on what antiplatelets you choose, whether it is single antiplatelets or dual antiplatelets, even dual antiplatelets, whether we sometimes you don't prefer clopidogrel and you prefer other agents as well. So can you tell the rationale for that? I'll first go to Dr. Raj and then your practice, and then I'll come to Amit here.
Really, I think if it is it all depends upon what is the core volume. So if it is a minor stroke wherein the core volume is less and patient has recovered post your thrombolysis, then the damage area is not high, then we can go for a dual antiplatelet. For a moderate stroke and large stroke, we still stick with single antiplatelet drug. So if it is a dual antiplatelet, so I go for aspirin and clopidogrel as my first choice. We have used ticagrelor and prasugrel in our interventional patients, and the prasugrel, of course, cannot be used in stroke patients. There were higher chances of intracerebral hemorrhage in patients who have had a stroke, so prasugrel is a no-no in stroke. With regards to ticagrelor, I think Dr. Amit can better answer. But there was a trial comparing ticagrelor and aspirin, and I'm not sure about the hemorrhage part. But in the coronary trials, the risk of ICH was higher with ticagrelor as compared to clopidogrel. So my first choice would be aspirin and clopidogrel. And with regards to chance trial, they had given 300 milligram clopidogrel because, as you know, clopidogrel, even if you load, it takes 6 to 8 hours to kick in. But if you do a everyday dose, then it's going to take a very long time for the clopidogrel to start kicking in. That all depends upon the core volume. If it's a large core, even if the deficit is smaller, then you'll have to be careful. And so this is my choice for the antiplatelets.
Dr. Amit,
So I
when do
concur
you
on
choose
that.
to get? Yeah.
Yeah, sorry,
When
you
do you
go ahead.
choose to get?
Yeah, so whenever we have somebody, as Dr. Raj rightly put it, if somebody has got a small core and a small infarct, so in that situation, I would be, comfortable putting him on dual antiplatelets. And my choice, as again he put it, is aspirin with clopidogrel. That would be my choice. While if there's a large infarct size, a very large infarct size, where the propensity of bleeding or hemorrhagic conversion is high, I would stick to a single antiplatelet, and my choice there would be aspirin. So I would start with aspirin and then see, and then take it forward from there. With regards to ticagrelor, I think most of these studies are showing a higher risk of hemorrhage and a hemorrhagic conversion. However, in terms of dual antiplatelets, when we start them together, they have got a lesser risk of, in terms of secondary stroke prevention, it's definitely better in the first, say, a few days, in the first 30 days or so. But the risk of hemorrhage with ticagrelor or a combination of ticagrelor and aspirin is definitely higher. So my choice in somebody of such a patient would be giving aspirin with clopidogrel as the choice if it's a small size infarct post thrombolysis.
All right. So, is there any role for therapeutic anticoagulation in an acute ischemic stroke scenario, even if the patient has atrial fibrillation? Dr. Raj.
Very interesting question, because I think initially you must have heard about the 1 3 6 12 rule, and now then that has changed to 1 2 3 4 rule, and now potentially the Elan trial, which we have been a part of it, soon be published. So in the past we used to think that large cores, larger bleeds, but somehow the it was a registry of I think 1,800 odd patients, which looked at NOAC initiation for patients with TIA on day one itself, and minor stroke on day two, moderate stroke on day three, and large stroke on day four. And they didn't really find higher chances of hemorrhage in the large infarct volume with a NOAC. So, however, it's not a randomized trial. So, the 1 3 6 12 rule was an expert opinion. Now, the 1 2 3 4 rule is based on 1,800 odd patients in the Europe, where they had initiated the small core at early period and the large core at day four, and they didn't find increased risk of ICH, whereas the stroke rates had gone down. So let's wait for the Elan trial. There are other trials which are coming up, looking at NOACs particularly early on in AF, whether it will increase ICH risk. There's one trial that was published from Canada, which was on dabigatran in the first 30 days, initiating early on, but that was in minor strokes and TIA, where they didn't show increased risk of ICH. So things might change in the near future.
So, your current practice?
Current practice, minor stroke, small core, I would start very early. I don't wait.
Dr. Amit, you agree with that?
Yeah, I agree with that. Probably high risk TIA as well as minor strokes, we would start it as early as probably day one, day two itself. And if it's a larger size, then I would be more comfortable waiting for a week or so. Uh, and, uh, uh, and and you can actually give Flexane or a low molecular weight heparin in the meantime, so that then we can start the NOAC. So that can be done when we can give a smaller dose instead of a complete therapeutic anticoagulation. That is one thing which is a middle ground.
So one of the other thing is you can look for other areas, like, so now we are doing MRI, so we do an SWS sequence. Also look at how much microhemorrhages are there. Okay, so if there are more than I think 10 microhemorrhages, then a higher chance of bleed. I also look for renal failure, liver dysfunction, all of these, and uncontrolled hypertension. So although the Hasbled score is not for post-stroke, it's for CHADVAS. There are multiple high-risk features, and you have to be careful in larger cores at least. The second thing I would say is, if it's a large, deep infarct, basal ganglia infarct, these are patients who are likely to bleed. So unlike the cortical infarct patients, so if there's a larger stroke but cortex, they are less likely to bleed as compared to an infarct which is in the basal ganglia. So, but yes, things will change in the near future. We'll have some evidence.
So, once you start in cases of therapeutic anticoagulation, you continue with antiplatelets or stop it completely?
I don't give both. So if you think AF is the etiology, just anticoagulant alone, dabigatran alone. And so the evidence is that, say, for example, where you have to have coronary artery disease, and you are a patient has had, say, for example, a stent put in the heart like 2 weeks ago. So in those patients, I give ADP antagonist is compulsory, because otherwise stent thrombosis risk is very high. So we have to give an ADP antagonist with a NOAC, and I continue that for a year. And beyond a year, I just, even if there is a coronary stent, I just put on a NOAC alone. There's no evidence to continue long-term antiplatelets.
All right. I think Dr. Amit agrees with you. And Dr. Saurabh, the last question. So these patients sometimes will need a DVT prophylaxis. So what is your protocol of DVT prophylaxis? Some patients, like we discussed, might be on single antiplatelet. Some patient will be on dual antiplatelet. Some patient, like you said, therapeutic antiplatelet, then that's a different issue. But patient who are on single antiplatelet, dual antiplatelet, if they need pharmacological prophylaxis, what do you do? or you just continue only with mechanical prophylaxis?
Our practice is to continue with mechanical prophylaxis. It is as true as possible. And though there is a controversial, so see, the evidence still is 2B. So we can't say that it is. And most of the, if you look at the society guidelines, they just recommend it. Neurocritical Care Society guidelines recommend to give pharmacological prophylaxis. I will say if there is a thrombophilia profile which is positive, and then there is a patient who is more prone to having a DVT, we generally should go for a pharmacological prophylaxis. Otherwise, our practice is to continue with antiplatelets and pumps, SCD devices. So this
So
is
the
this is
last
what we
question of
usually
the day
practice.
about decompressive craniotomy. So, what is your protocol? You go for an early decompressive craniotomy based on the MR, or you wait for the patient to deteriorate? Let me start from Amit. Yeah. In case of malignant
So,
strokes.
so if it's a malignant MCA stroke, we do not wait for the patient to worsen. If you know that this patient has he's out of the window period, there's no revascularization possible. We start discussing with the patient regarding early decompression, and of course we have to discuss and tell the family and take them as early as possible. Yeah, because waiting for even for a few hours or waiting for 1 day or 2 days, you never know, you may have to take the patient up for emergency decompression. So in a malignant MCA situation, I would definitely counsel the patient for an early decompression as early as possible.
Dr. Raj, you follow the same protocol, or you wait for the patient to deteriorate? And
I mean, if it's a young patient, we do push for decompression early, because I think the evidence is for as of now less than 60 years of age. I mean, I've really not looked at literature now recently, but older patients, we are tending to wait for clinical worsening potentially, or any change in their level of consciousness, and then we go ahead, because 70s and 80s we sort of wait.
Dr.
With
Saurabh,
large
in this
versus
case,
malignant MCA, large versus malignant MCA. So malignant is something where the entire thing is infarcted out. I agree, of course, above the age of 70 or 80 years, you could still wait and explain the clinical situation, and more so if the patient has lived his life.
okay.
Yeah.
So to close this discussion, Dr. Saurabh, in these malignant infarcts, even if the patient is okay, do you start a regular hyperosmolar therapy like manitacid, hypertonic saline, or use those only when the patient deteriorate as a rescue therapy where it is shown to be absolutely beneficial? What is your
We
take
generally
here?
only don't start it in the first 24 hours. This patient is going to develop an edema on most of the time it's on the after 48 hours or the third day or so. So it's generally not our routine practice to start in as soon as the patient comes. Yes, in a malignant MCA, in fact, we generally go for an hyperosmolar therapy early on, and if we have to wait, supposingly we just have to cut down the night and we are going to plan a decompressive craniotomy early morning, something like that. But most of the time, we start hyperosmolar therapy on day 2, I will say after 48 hours or so. This is our usual practice in our institute.
Okay, so with this, we'll come to the end of today's discussion. I must thank Dr. Rajsrinivas, Parthasarathy, Dr. Amit Kulkarni for your wonderful inputs, Dr. Saurabh Anand, Dr. Manish, Marda, and Dr. Prasanna, our regular faculties here. Thank you so much for coming and expressing your views on today's masterclass. Thank you so much, Dr. Raj, Dr. Amit.
Thank you very much for inviting us. Thank you.
Thank
Pleasure
you.
being.
Thank you.
So we are coming to the end of today's discussion. Tomorrow we'll be having two lectures, one on I, another on T. I'll all see you tomorrow. Good day. Thank you.